Hi there, my name's Rachna. I'm a GP and a clinical lead for Clinical Effectiveness Southwark. We're going to be talking about COPD in the context of COVID. I'm just going to share my screen so that we go to the website. Our website, clinicaleffectiveness.southwark.co.uk, has all of our guidance. If you click on guides there in the corner, and then you'll see this page, scroll down to the bottom, the COPD guidance is there in the middle. So I'm just going to orientate us around the guide. The first page has our key messages. The first key message is around diagnostics. So spirometry is not available at the moment because it's aerosol generating. How do we then use peak flows to help us support a diagnosis of COPD? The second places an emphasis on optimizing medical management for our patients because they are at an increased risk of having adverse outcomes from COVID pneumonia. And the third is on oral corticosteroids. We shouldn't really be using them for COVID, but for an exacerbation of COPD, there still remains a place for steroids as there was before. So if someone has concomitant asthma or has been steroid responsive in the past, or indeed has raised eosinophils, it's fine to use them for a short course. The second page has a schematic which helps to differentiate between respiratory symptoms that can help us to make the diagnosis. Worth just focusing a little bit on a couple of lines. The first is fever, more in COVID, less so in an exacerbation. The second is wheeze, more so in an exacerbation, not so much in COVID. And the third, a red flag, and that's within the context of COVID. Clotting disorders are more prevalent. So if someone does come in with pleuritic pain, do think in the back of your mind, could this be a pulmonary embolus? The next page really goes into a lot of detail about how to make a provisional diagnosis of COPD using peak flow at home with the patient, which you can help them to understand how to use better using perhaps a video consult. There's also some guidance on here on which medication you would then trial. So typically it would be a LAMA, and the importance of coding these patients properly. The other side places an emphasis on the importance of reducing the risk of an exacerbation, which is really, doing the basics that we know. So smoking cessation where appropriate, vaccinations, and pulmonary rehab. The next page talks about the context in which you would use oral corticosteroids. So in an exacerbation, like I mentioned, you would for these criteria. The little bit here on oral antibiotics is taken from NICE guidance, which essentially says that for people where their symptoms are mild, you perhaps don't need to offer an antibiotic, but if someone is at high risk of complications, and most of our COPD patients are, we can consider antibiotics. The bit on the bottom talks a little bit about care planning and the importance of having appropriate conversations in the context of COPD that's severe. And there are some criteria on the other side with regards to assessing the need for hospitalization in the context of using saturations. And the very last page is just an advice page of things to remember, including Consultant Connect, the at-home team, and of course, the usual referral pathways. Thank you very much.